Right. Good afternoon. Thank you all for coming here and then listening to our discussion on lung cancers. So we all hear about lung cancer, so I'm here to try to enlighten and give you some information as well as trying to hopefully all of us have a better understanding of lung cancers. Just personally, how many of us have experienced lung cancer, know people who had lung cancer or people who died from lung cancer? Okay, quite a few of you, all right? Right. So my story today starts with a rabbit, right? Not this rabbit, all right? So it was this rabbit dish, okay? So she was a psychologist. She studied in UK and she went traveling around Morocco and had a street side food called rabbit tagine, which is how they cook with spices and peas and potatoes. So after that, she developed some pain around the body, felt tired, felt weak, and then came back to Singapore for further treatment, right? And she also had weight loss as well, right? So, but she's still able to work, still able to function normally as a psychologist. So when she got to Singapore, we found that she had a lung cancer. You can see from the scan on the top right, there's something in the lungs. It also spread to her pelvis. So the time she was diagnosed, it's actually quite an advanced stage lung cancer, right? And she was offered treatment, but they were quite limited because of all the studies were all negative for all your mutations. And it still progressed despite treatment. And what happened after that? Because she started in UK, she went back to Cambridge, tried to seek treatment there, did not succeed, all right? And eventually she passed away after 6 months from the point of diagnosis, very rapid. And she had never smoked. She had no family members with lung cancer, and she was only 34, so very, very young, all right? So very unfortunate, okay? So her husband was quite devastated because so far 6 months, right? So how bad can lung cancer be seriously, right? So we look at data from this was published in 2025, just last year, the Singapore Cancer Registry. And what they found was that the incidence of cancer, how many cancers that we are facing per year, comparing 2008 to 12 to the current, the numbers are rising. Not that good. But then again, somehow mortality is coming down, and which is a good sign. So although you have cancer, you can survive. And what's importantly is that your survival rate at the end of 5 years is actually better. So with better treatment, better options, people are surviving longer. But you must remember that surviving with cancer doesn't mean living. You could be surviving with cancer, you're bedbound, you're in a wheelchair, you can't work, you depend on people to feed you. That's called surviving, but it's not called living. So that's where sometimes we must know that trying to live with cancer and survive with cancer is a bit different. All right. So looking at the data from this study, current cancer is number 3, all right, and not a small number as well. And if you look at this study as well, who actually has cancer younger is the women, all right. And if we reach 75, which hopefully all of us will be able to reach, your risk of developing some form of cancer is 1 in 4. So if you raise our hands, lung cancer was about maybe 15, 20 people. A quarter of us will have some form of cancer when we reach 75. Right? And if you are below 60, your chance of developing some cancer much higher for women. So cancer is an ever-present problem, and we're going to face it more, and we'll have to learn how to deal with it. All right? Now, this big slide, which I'll differentiate a little bit later, talks about the racial differentiation between cancers in Singapore. And we're looking typically at lung. So look at the Chinese. Lung cancer is number 3. Again, more men than women. You look at the Malay population, lung cancer is number 1. And we are not too sure. Is it environmental? Is it genetic? It's possible. If you look at the Indian population, and lung cancer again goes back to number 3, but the Indian women actually have a lower incidence. So there is a racial differentiation between for lung cancers in different groups as well. So supposing you're diagnosed with lung cancer, either through oncologists, through biopsies, what happens then? All right. Is it good news? Is it bad news? Can it get worse? All right. And that's where we talk about staging of your lung cancer. All right. Now, staging of a lung cancer, basically to tell us how bad it is. Where's the disease? Is it still in your lungs? Is it somewhere else? Is it spread to somewhere, other part of the body? And therefore, this staging guides treatment. Because if you're stage 1, you don't treat as stage 4. All right, that'd be the wrong treatment. Or stage 4, the doctor says, oh, let's do surgery for your lungs. No, it's wrong treatment. So the staging tells us what is the best treatment for you. At the same time, it tells you what's your prognosis, because based on data around the world, stage 3 survival rate is this much, stage 1 survival this much. And it will help us determine along the way whether your treatment works or doesn't work. So staging is not as a one-off, it continues to have need for assessment throughout your whole treatment of the cancer. So if you look at lung, okay, you've got even this stage called stage 0, which I'll explain a little bit of detail later, right? Then you're 1, 2, 3, 4, the longer you delay your diagnosis, the longer you don't seek treatment, you can go from stage 1 to stage 4, okay? The duration can be quite fast or quite slow. So how do you talk about stage 1 or stage 0? So to find an analogy for stage 0, I use this as a zombie apocalypse. A lot of us watch World War Z or some zombie movie. Stage 0 is, it has not become a cancer yet, but there's a potential to become a cancer. Just like a zombie, you got bitten. You got maybe a few minutes, few seconds, depending on which movie you watch, right? So before you even transform to a zombie, that's stage 0. So you're not harmful yet, but you have potential to become harmful. Stage 1, one single zombie, right? You remove the zombie by any means, you can cure the problem, all right? But stage 2 means it's a bigger problem. You have more zombies, right? So taking out one zombie won't help you. Stage 3 is spread within the same country or the same organ. And the stage 4 becomes a worldwide epidemic, right? So that's how you can tell what's the difference between stage 0, which we all want, and stage 4, which we don't want. So why is this staging so important? Because staging can take years to develop from stage 0 to stage 4, or like our patients, sometimes even months. So we cannot predict like, oh, I got a week of stage 1, I've got a few years. No, you can progress from stage 1 to stage 4 within a few months. It depends on how aggressive the tumor is, right? Now, in this busy slide, all right, I'm just to tell you historical data about men. This is blue, okay, so male, all right. Now, in 2003 all the way to the current, right, stage 1 cancers actually are increasingly being diagnosed, which is a good sign, which means people are going for screening, people are going for tests, and we are picking up stage 1 cancers earlier, which is good because stage 1 gives you a better chance of survival. But the problem is your stage 4 is also persistently high. So we are still diagnosing people at stage 4 cancers, which is not good, right? And that's something which is something we need to improve over time. And despite almost 20 years, the numbers have not changed. Now, how about women? Dramatically for stage 1, big number of women actually have detected stage 1 cancer, which is good because we can institute treatment, we can secure, we have surveillance, we prevent it from becoming stage 4. But again, stage 4, you can look at the numbers, it's still horribly high, about over 60%, sometimes 59%, so bad. So stage 4 is still being seen, even though with our modern techniques of identification, health screening, and over 20 years, no change, right? Now, we all know, based on this big list of cancers, which is the most, we all know is always bad, it will be the pancreas, right? Okay? Okay, pancreas is number 1. Once you know friends who have pancreatic cancer, usually they die quite in pain, quite fast. So, pancreatic cancer, based on this study of survival, after 5 years, 12%. And what comes at second is actually your lung cancers. Okay, so cancer for the lung is not that great once you have a diagnosis. So what does it tell us? We want to capture lung cancer early. We don't want to capture it late, right? So early diagnosis is always better. Then again, you must know that you detect early doesn't mean 100% survival, okay? Again, you detect late cancer, stage 4 is not 0. And this is because there are treatment options available, which my colleague will speak to you about later, with patients that are stage 4, rare, but they have survived for years with advanced medical treatment, ongoing medical trials. Just don't wait until stage 4 and expect you to be in that 16%. I'd rather take our percentages with 97 than with 16%. Okay, so it's like, don't assume you will be one of those that are lucky ones, right? It's like playing roulette with 5 bullets out of 6. Right, so why is it so difficult to detect cancers, and why do patients present with stage 4? It's because of 2 big issues. One is people think pain must be cancer. No pain equals no cancer. But if you look at the anatomy of the lung, all your pain fibers are located on your chest wall. There are no pain fibers in your lung. So as a result, if there's something growing inside your lungs, you won't feel pain until it involves the chest wall. And that means quite big, quite advanced. Right. Second thing is coughing. People think you must have coughing, then you have some lung cancer. You have no coughing, not likely to have lung cancer. But again, a lot of things can mimic coughing. Asthma, COVID, influenza, pneumonia can cause coughing. And people think, but if a short duration, that's bad. Second thing, all your cough nerve fibers, you can see your coughing nerves are in your air passages, your big trachea, as well as your bronchus. In the lung, no cough fibers. Unless you involve the air passage, then you develop coughing. By that time, the tumor might be pretty large already. Okay, so that's why people think no pain, no cancer. Actually, is not true. You can develop cancers without pain. All right. And the next thing is, we all go for health screening. We go for x-rays, we go for yearly x-rays, we go sometimes half a yearly x-ray, and we think, hey, the x-ray is fine, no cancers are seen. But a few things we must know is that the x-rays don't see the entire lung. There's part of the lung hidden behind the heart, behind the bones, behind the ribs, behind the clavicle, and you cannot see it in the x-ray. So you can see these x-rays look normal, but over time you can see there's a tumor developing. And therefore, x-rays are not the best way to screen for cancers. Again, hiding behind all these structures like your pulmonary artery or where the arrow is, you can't see a tumor until it becomes much larger. And by the time it's no longer stage 1, it could be stage 2 or even 3, right? And in this study was published actually in 2011. They compared patients with doing x-ray, no x-ray, and they followed them after like 13 years. Was there a difference in cancer survival? And basically showed no difference. So cancer survival was not dependent on whether you did x-ray or not. So the x-ray actually was not important, right? So what do we do when we are suspecting a patient of cancer, you want to screen for lung cancer, is what we could do, we call the CAT scan or the low-dose CT scan. So a CAT scan is very non-invasive. You lie down on this bed, okay, you go in and out, basically you end up with a scan within 5 minutes, all right? Okay, the radiation is much less. Okay, in the past we used to do a lot of CT scans, the radiation was quite high. So assuming like X-ray is 1, previous scans used to be like equivalent to 70 X-rays, which is quite a lot. So the low-dose CT scan is able to reduce the amount of radiation to like maybe 8 to 10 X-rays. So quite safe. And it takes about 5 minutes. Hold your breath, go in, go out, done. Okay, but it's not 5 minutes. Like, you must have waiting time. Patient must go in, register, wait for your turn, go in, come out. So this is not your McDonald's, okay? This is a bit more complicated, like McDonald's with maybe the high-end McDonald's. But still, 30 minutes is very fast, and you have your results almost immediately, right? And it's painless because there's no injection, there's no need to put an intravenous line into you or give you medications to enhance all your blood vessels. So it can be done quite easily, quite readily, and takes a short time, right? You don't need to fast, okay? Unlike some patients who have gone through scans with the abdomen, ultrasounds, you have to fast. This one, no need. Okay, you just had lunch, go for a scan, come back, you can see your results within half an hour. So why don't we send everybody for scan? The problem is, okay, we'll talk about later, is you can see, based on this study, again in 2011, this is called a low-dose CT scan. It was a big trial that looked at how to screen for lung cancer. And they found that when you do this low-dose CT scan, you actually can detect cancers earlier. And at the same time, you can actually reduce death. So detection is one, preventing death is actually what we all want. And this scan actually proves that doing the scan can reduce death from lung cancers. So why do we scan everybody? Because there are cons to doing the scan. One is its cost, all right? It's not like an X-ray is quite cheap, but the scan is a bit more expensive, like maybe 5-6 times the price of an X-ray. But again, the radiation is about 8 times, so it's actually not too bad if you do it to reassure yourself or you're high risk. At the same time, it's still radiation. And you have people that are really kiasu. I want to scan every 3 months. Sure, but you accumulate the scan, and women, because of your breast tissue, your breast accumulate this radiation. Your risk of developing some cancers, not because of lung cancer, but because of radiation, is a bit higher over time. So unnecessary scans is bad. Important scans, good. Okay? Next, the problem is that these scans, you detect everything. Whether cancerous, not cancerous. Like you go fishing, I throw a net with huge holes, I catch nothing. I have one with tiny scopes, I catch the boot, I catch the straw, I catch the fish, I catch the go inside, I catch all the nonsense also. And you can't tell what's the difference. And that's where scans sometimes pick up things which you are not cancer, but now you tell the patient there's something, they get worried, especially those who are very paranoid. They get worried, they can't sleep, they can't think, they can't work. So that scan can lead to some stress as well in these patients, right? And can lead to anxiety. So this is an example of how we do a scan. Let's say we scan 1,000 people, right? Okay, there are some people that actually don't want to scan. I don't care, I die tomorrow, it's okay, I'm happy, I live a good life. All right. Then what happens? There are lots of people we scan, ain't nothing. Good. This is the group you reassure them. But then you must know that you screen negative now doesn't mean screen negative next year. That is the thing. You can assume that one scan is okay, you have a life. No. Cancers can develop down the road. Now, you have a small group that shows got some problem in your scan. Doesn't mean every scan we must act on it. Sometimes we say, okay, it looks like a scar tissue, could be a lymph node, or you have very bad COVID. Yeah, it could be some scarring in your lungs. We just keep an eye on it. What happens are those who have a scan, you find something, you go for a procedure, either biopsy or some scope, and you find out negative. Good, everybody's happy, right? Then there are those which you screen for cancer, you overdiagnose, or you think it could be cancer, and you do scans or you do biopsy, turns out to be nothing really much. The last group are the ones you actually screen and detect cancer, and you prevent a death, right? So this number out of 1,000, it's actually 0.003. So the problem is, you look at the numbers, it seems so low, but then why do we do it? The problem is, if you're number 3, or one of those 3, your life is saved. And when you save patients from late cancer, early cancer, you detect early, like 30 or 40 years old, they still work for the next 30, 40 years. They can still have family, they still have kids, they have grandkids. So by saving one life, you don't just save the life of the person, you save the life of your future generation or the family, right? So that's where economics becomes an issue when you do a scan. So the question now is, how do we scan? Or who do we scan? As a result, with all government, okay, with all this dilemma, we come up with guidelines. So guidelines will tell us who to scan, how to scan, when to scan, and when not to scan, right? So we go through this little table much more detail, right? But basically we have these recommendations, right? Some of you may fall in this category, go for a scan. Some of you may not fall in this category because guidelines cannot tell everybody. They give you the general population. So we go for the biggest bang of the buck. Who are the most likely people to develop cancer in this group? But we know a lot of patients, non-smoking, also develop cancer. So this is only a guideline. It's not a rule, it's not a law. Okay? They are only guidelines. So look at these guidelines. To make it simple, annual screening once a year. Okay? So the 3-month scan, really not necessary, unless we find something. Right? It's a low-dose CT scan. If you're between this age group, 50 to 80, you recommend you go for a scan. You smoke 20 pack years. So what does 20 pack years mean? You smoke a pack for 20 years, for a day for 20 years. That equals to 20 pack years. So if you like smoke 2 or 3, casual smoking over the weekend, you don't fall into this category, right? Or you quit smoking, very good. More than 15 years ago, less than 15 years ago, then you should go for a scan because your risk of cancer decreases each year you stop smoking, but it doesn't reach 0 until around this time. So you have stopped smoking and you're still within this 15 years, you recommend a scan. Okay? They mentioned non-smokers, don't go for a scan. Okay, but again, this is guidelines, right? At the same time, when do you not do a scan? People who have quit for more than 15 years, or basically, go back, who have unwilling, or basically got a medical condition. He's got a heart attack, his heart is failed, he's in bed all the time. Doing a scan for him doesn't make sense because you detect lung cancer, he's not fit for surgery. So therefore, these are the patients we will probably not recommend a scan. Because if you did get scanned, well and good, but you can't do anything about it. That means we don't bother to put them through this unnecessary test. So what else hope is there besides the scan? And what we talk about is now AI, right? Now all of us heard about AI in the news here, there, the good news, the bad news for AI. But AI can be good to good news. And people have used AI in radiation, in CT scans, or even in X-rays. And what they've done is that they can train the AI to look at X-rays, look at CT scans, and give you an idea of whether the risk of cancer is high and low and whether to go for a scan. And they have found that they are able to train the AI to look at X-ray. If you think it's a cancer risk, go for a scan. So that's where utilization of AI, in that sense, is not bad. So how does AI work? You put in all the parameters, smoking behavior, your medical history, your blood test. Then it comes up with the algorithm and your x-ray. You find out whether you're high risk or low risk for cancer, all right? And therefore it helps you to decide who should go for screening, who should go for screening. So some people combine both, CT scan plus AI. And actually it leads to even higher pickup rate. But again, with AI, you pick up more. Sometimes you pick up unnecessary things. But we can train AI to pick up which is the unnecessary, which is the necessary, and which is the important. And this AI is being trained, and therefore they can tell us likely benign, then don't worry, but likely cancer. And this is data based on thousands and thousands of scans, right? So we have this huge database of scans, which turn out to be cancer, not cancer. We can input and then help you to detect cancers. So, in summary, after this talk, if you have lungs, you can get lung cancer, right? Yeah. Right? So don't assume that you will never have lung cancer, but then don't be paranoid that think you'll always have lung cancer, all right? But the idea is when you fall the category, do a scan, if you have a diagnosis of possible lung cancer, treat it early rather than treat it late, okay? Thank you very much.
Thank you so much, Doctor.